Hi, this is Brian Kim. I'm going to share with you this case of a patient with a dense cataract. And as I'm performing this cataract surgery, I start to notice some unusual things about the case. Namely, there's significant zonular dehiscence with vitreous prolapse. And you can see how I handle disassembling this lens in the context of this zonulopathy. And I choose to place a Sulcus AR40 lens with optic capture. So you can see this is a cotton tip to steady the eye. I'm using a cotton tip to control the eye and use a corneal marker which will help me to center and size the rhexis. This is my paracentesis blade, first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is the patient's right eye. This is intracameral epinephrine, and then some dispersive viscoelastic. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter. And this is the microrhexis forceps puncture technique. I push some more dispersive viscoelastic, puncture the center, pull down towards me, grab the right side of the tear, go around circumferentially, making sure I try to align the rhexis with the corneal mark that I made earlier. Thus far, I don't see any signs of any significant zonular disease. In my experience, I'm able to identify and detect the zonular disease with the rhexis, but again, I didn't find any. This is the capsule fornix hydrodissection technique. I place the cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave, try to decompress the bag, sweeping under the rhexis edge, under the right and left side. Turning on irrigation, irrigating the surface of the eye, adjusting the sleeve, lifting the incision with the chopper, go in with irrigation off to minimize Dehiscence trauma. Turn on the irrigation momentarily, and then removing the surface epinuclear material, sliding the chopper under the rhexis edge contra-incisionally, turning the phaco-tip vertically sub-incisionally, trying to flank the lens. You can see the density of the lens, the whitening of the lens as I fracture the lens with the double chop maneuver using mechanical fracturing. Sliding the chopper under the right heminucleus, hooking the peripheral lens, pulling it centrally toward the phaco-tip, and fracturing the lens against the phaco-tip, and that is the double chop maneuver. Using some vacuum to grab that first quadrant up, getting the chopper around it, and then crushing it with manual forces. Crushing it between the instruments again, and then emulsifying the lens pieces. With these dense lenses, I want to leverage manual fracturing techniques by crushing the lens into smaller pieces using my instruments. Sliding the chopper under the second quadrant, pulling it centric toward the phaco-tip and fracturing the lens again in half, using the high vacuum to grab some of those pieces, and then crushing the lens with the instruments, and then pulsing with the phaco-tip and removing the lens pieces. So far, this seems like a fairly routine case. Turning the second heminucleus in front of me, grabbing some small fragments. I don't want to pull too much because the lens seems a little sticky, so I just use some vacuum to grab that second heminucleus up out of the bag, and then getting the chopper around the lens and fracturing it into smaller pieces, breaking up, essentially creating a third quadrant, and then using the instruments to manually fracturing the lens into smaller pieces and then emulsifying the lens piece. Grabbing that last quadrant up out of the bag, getting the chopper around the lens, crushing it into smaller pieces, using some vacuum to control the lens piece, again getting the chopper around it, crushing it with the instruments, and then emulsifying the lens pieces. Again, pulsing the phaco-tip so that I use sparing amounts of ultrasonic energy and vacuum. Gently grabbing and turning that last quadrant around using some vacuum, and then manually with the chopper as well, crushing the lens into smaller pieces, again holding it on the tip with the phaco-tip, which has excellent holding power, holding ability, and then crushing the pieces against the chopper and then emulsifying the lens pieces. So all the endonucleus is out now. There's a little bit of epinucleus there. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the ironing handpiece. There's a little chip that's on the tip here, so I'm using the cannula to mash that endonuclear piece. Starting sub-incisionally, removing the cortical material and the epinuclear material, peeling it from anterior to posterior. Now going to the right side, peeling from anterior to posterior again. Starting superinasally. Peeling some cortex. But as I do this, I start to see some zonular weakness. Again, at the supratemporal location, you can start to see the edge of the capsule fornix coming into view near the pupillary edge. And so that is an area of zonular dehiscence. I'm not sure if I noticed that at the time of the surgery in real time, but I'm seeing it now. But now that I've got most of the lens out, I'm starting to see something's acting a little funny. So you see I stop. I'm trying to figure out what's going on. I turn off infusion, pushing dispersive viscoelastic to fill the bag. And I'm not even sure if the bag is completely intact. I'm just doing this to really kind of get an idea. And as I push more dispersive viscoelastic, it's helping to protect the bag. And I remove some pieces of cortical material as well. I'm checking the incision. So I checked for vitreous, but fortunately there was no vitreous to the wound. I enlarge my incision, and this is the Sensar AR40 lens. I place the lens on the cartridge, making sure it's seated down. When I bend it, I want to make sure that the lens bends backward concavely. You want to make sure the leading haptic goes into the barrel and the trailing haptic comes out of the back end. This is the same lens I use for my Yamane technique. This is some cohesive viscoelastic. I'm creating some space in the sulcus and placing the AR40 lens into the sulcus. I've identified at this point that there is an area of zonular dehiscence, and so I feel like this might be the best way to stabilize the lens, because otherwise the bag is intact. There's just some focal area of weakness. So I'm going to dial the trailing haptic into the sulcus and then optic capture the lens in a buttonhole configuration. And by doing it this way, the lens is going to be stable. And I also feel like by doing it this way, if there is any future issues with the lens dislocating, I can always Yamane this Sensar lens. I go in with the ironing handpiece, start to remove the viscoelastic from the anterior chamber. I take the ironing handpiece out and hydrate the incisions, and that's the end of the case. So again, there's clearly some weakness, some folds in the posterior capsule, clearly some disturbance to the zonules. I was not sure if I was responsible for the zonulopathy. Now that I've reviewed this case, I don't see anything that I have caused to strip more zonules, but clearly there was something going on, and it was noticeable when I took out that last endonuclear fragment and when I started to clean the epinucleus and cortex. So I did a sulcus placement of the AR40 lens with optic capture. There was no vitreous at the end of the case. The lens is nice and buttonholed through the rhexis opening. Lens is nice and centered, and there was no vitreous. When I did this case, I really thought to myself, maybe I did something, maybe I caused something. But again, like I said, reviewing this case, I don't see anything. And you will see in a future video this patient's second eye, which proves to me that it wasn't iatrogenic, that this patient does have zonulopathy, and you'll see that as well on the second case, which I handle with a slightly different technique. So I hope this was helpful to you, and I thank you for your attention.